nugera kuri stade umbwire ni hafi ya kuri stade. Kugenda ndasabye gukora inama sibyo.
Aaron, you are now co-host. Can I start admitting people?
Yes. Hello, everyone. Hello. Thank you so much for joining, everyone. I would like to thank you so much. As we're waiting for other people to join, please remember to mute the microphone so that you don't interruptions. Yeah, thank you so much. We'll start in like 3 minutes. Let's wait for everyone to join and then we can start. Thank you so much. All right. Thank you everyone for joining. My name is Mutoni Allen and I'm going to be your moderator today. I hope everyone can hear me. If you cannot hear me, say hi in the chat box so that I can know that we are all following. You can also greet each other in the chat box, say hello so that we can start off. Yeah, thank you so much. Yes, so I'll start by giving the guidelines for this workshop. This workshop is has been prepared by the National Research Foundation and Health-Edu Limited. We have different presenters, doctors that are going to take us through the session. We have Dr. Ulimboni, we have Dr. Daisy Mutoni, and we also have Dr. Aline Uwase. So these doctors are going to take us through the different sessions. This is an up-to-date call for healthcare providers on COVID-19 mutations and vaccines, and also health providers burnout. So as we start, I'll request us to have our microphones on mute so that we don't interrupt the presenters while they're giving us the sessions. I will also request each one to have their real names on the non-device names. For example, I can see some participants with names like Galaxy A5, Infinix 4010K. So please change your names to real names. This will help us in giving out of certificates. Yeah, thank you so much. Yeah, so for reading materials like the presentations that will be used by different doctors and during the presentation, you can get them from health-edu.org. You can visit our website and then you can get them from there. The link will be shared in the chat box below. So please click to the link and then you can be able to get the presentations from there. Yeah, so without wasting time, I would like to welcome Dr. Daisy to take us through the first session on vaccines. We all have.
Hi, Alan. Sorry, could you let Dr. Uri start? He will be starting, if that's okay.
Okay. Yeah, I can see. Sorry for that. Yeah. So we are going to have Dr. Uri starting with mutations. So I will welcome Dr. Uri to start and give us the presentation. Thank you so much.
Okay. I hope you can all hear me well, and
Yes.
also that you can see my screen.
Yes, doctor, you can see it.
Okay. All right. So thank you to the organizers for the opportunity to attend and present at this workshop meant for healthcare providers. And to the healthcare providers, welcome all to this workshop. I should start off by saying that I applaud you all for the noble work that you're doing in ensuring the good health of everyone in your respective communities and in Rwanda at large. Let me go ahead and introduce myself briefly. I am a research scientist based here in the US. I'm obviously Rwandan, but based here in the US. And my area of research expertise is on a virus that is different from the SARS-CoV-2 virus that we're going to be discussing today. So I study the molecular biology of HIV infection, and more specifically, researching on ways to eliminate the form of HIV infection that cannot be cured with current antiretroviral therapy. My presentation today will be in two parts. So I'll be giving you my presentation in two parts. So the first part will be essentially providing an update on the newer developments in this fast evolving COVID-19 pandemic. And then the second part has actually been pre-recorded. So I'll be projecting to you a pre-recorded presentation in my second part. And I'm hoping that will offer an opportunity for us to engage with one another using the chat feature and have an interactive Q&A discussion. So to start off, so let me briefly summarize the current status of this COVID-19 pandemic. So during the period of the pandemic, so during the past 1.5 years or so, it's taken quite a massive toll on the human population. So close to 4.5 million people have died of COVID-19 since the start of the pandemic. And currently, this Delta variant of concern, which is much more transmissible, much more infectious, and much more transmissible than the original Wuhan strain, and this will be discussed in more detail by Dr. Daisy and I in our presentations. So this variant of concern is now currently the globally dominant SARS-CoV-2 strain. And vaccination with these WHO-approved vaccines still remains a key strategy for the control of the COVID-19 pandemic, even against variants, including the globally dominant Delta variant. However, there is clearly a disparity in the equitable distribution of these vaccines globally, because although about just over 30% of the world's population has thus far received at least one dose of the COVID-19 vaccine, with about a quarter of the population being fully vaccinated, only a little over 1% of the eligible population in the developing world have received at least one dose. So there's clearly a disparity in the regional distribution of vaccines globally. And there is reason for concern about this, because people in the developed world are now calling for a third shot booster or for booster vaccinations, and campaigning for these booster vaccinations is clearly a reason for concern, because it will further worsen the already dire inequity in the global distribution of vaccines. So, are the current vaccines efficacious against these variants of concern? Well, first of all, our key defense against the COVID-19 pandemic, once again, in addition to these restrictions of wearing masks, maintaining hygiene, and exercising social distancing, are antibodies that can neutralize the virus, the SARS-CoV-2 virus. And these antibodies are usually generated by either by vaccination or upon a natural infection and recovery. So yeah, so these neutralizing antibodies are elicited in response to either a natural infection or by vaccination. Okay. And in protecting against the Delta variant, it's been shown that full doses of either the mRNA vaccine or the AstraZeneca DNA vaccine are highly effective. So they're not just effective against the original Wuhan strain, but they are also effective, highly effective against the Delta, the globally dominant Delta variant. And for the Alpha variant, these two dose regimens of either vaccine are also highly effective. So at the moment, the expected benefits of booster vaccinations are really small compared with the case of using those doses on unvaccinated people. However, I should point out that the notable exceptions, so the people who would need a booster vaccination or who would be in need of a third shot booster are immunocompromised individuals, who include the elderly, patients on chemotherapy, and also patients who've undergone an organ or a bone marrow transplant. So with a constrained global vaccine supply, it is unethical to provide booster vaccinations as long as the two-dose regimen continues to provide protection against variants. And this sentiment has also been echoed by the Director General of the World Health Organization. So therefore, the equitable distribution of vaccines will also reduce the chances of the emergence of more transmissible and more pathogenic variants. So there's an added advantage. So this statement indicates that there's an added advantage to an equitable distribution of vaccines. Okay, so not just protecting everyone globally, but that also it does indeed reduce the chance of emergence of variants that can prove to be highly transmissible and pathogenic. Okay, so what about the status on COVID-19 treatment? So two major approaches to the treatment of COVID-19 patients, in addition to oxygen therapy, using repurposed drugs, more specifically, or in most cases, antiviral drugs, or using what is known as a monoclonal antibody therapy. And just to provide you with an update on research and development as it pertains to these two treatment approaches. So there is a study that came out. It's actually in preprint format, so it hasn't been published yet. So prior to that, a phase 1 clinical trial study showed that this antiviral drug, molnupiravir, which are shown here to the right, so it's actually taken orally through the mouth as a prodrug, and once in the body, it gets metabolized into its active form. Then the active form becomes incorporated into the virus during its replication, and as a consequence, viral replication is disrupted. So this drug was shown, first of all, in a phase 1 trial to be safe and well tolerated. And then in a more recent study, so a phase 2A clinical trial on symptomatic patients, this more recent study demonstrated that a daily 2-dose regimen of this antiviral drug for 5 days is effective at clearing viral infection as measured by RT-PCR and the isolation of infectious virus from nasal swabs. So this is the first time that this antiviral drug is being clinically tested in humans. And it's a promising drug because it's proven to be a better antiviral drug compared to, for instance, remdesivir. So there is promise in the use of a repurposed or a small molecule compound for the treatment of COVID-19. And secondly, there's still efforts to continue to identify neutralizing monoclonal antibodies that have a broad spectrum profile. Therefore, monoclonal antibodies that don't just target one particular strain of the virus, but all of these circulating forms of the virus, including the variant forms. And these studies usually involve harvesting blood from recovering or convalescent patients, or even from vaccinated individuals, in order to screen their blood and identify, isolate, and then scale up antibodies that have a broad and effective neutralizing capability on the existing strains of SARS-CoV-2. So before I project the second part of my presentation, the pre-recorded presentation, let me first provide an outline of this second part of my presentation. So, so the presentation will discuss the risk factors for developing COVID-19, the various forms, acute, severe, and long-term subacute to chronic COVID-19. We'll make the point that COVID-19 is not just a respiratory infection, but also a systemic disease. And we'll discuss these vaccines that have been approved for emergency use, particularly at protecting against these circulating variants of concern. We'll provide an update on the development of rapid, affordable, and accurate testing for SARS-CoV-2. And finally, briefly discuss these treatment strategies, monoclonal antibody therapy, and some of the and the repurposed drugs. So with that, let me go ahead and project my second presentation here. All right,
Hello, Dr. Uri?
hello?
Yes, we
Yes, yeah, I'm trying to find my, hold on just a second here.
All right, thanks.
Give me a second. I'm trying to find the, I seem to have lost the, my Zoom.
No, it is fine, take your time.
Okay, hold on just a second. Okay, so new share, okay. And then, so can you see my screen?
Yes.
Okay. So I'm hoping that the volume will be loud enough. The pre-recorded volume will be loud enough for all of you to hear. If not, please try and increase the volume on your speakers. And if that doesn't work, we'll troubleshoot. Okay. So moderator, just let me know if the volume is loud enough.
All right.
Okay. So I'll go ahead and start the presentation. The second part of the presentation.
Hello, Dr. Uri. Has it started yet or?
Yeah, yes, it has started.
With the volume?
Yes, the volume is on. I can hear it from my end. Can you hear it from your end?
No, I can't.
Okay.
It's just I think screen sharing.
Okay. Can you see the laser pointer?
Yes.
Okay. So let me do this. Let me forward this presentation to you and see if you can project it from your end.
All right. I think Agnes can help with that. Hello, Agnes.
Yes, hello.
Yeah, could you share just as presentation?
Well, the screen is there. It's shared.
No, he's trying to see if you share it in a sound here from this one.
Oh, okay. I can
Okay.
share
Okay.
it.
So let me. Okay. So let me try this again. Welcome to the second part of this presentation, which has been pre-recorded. During this presentation, I'll be
Hello,
answering
Dr. Uri.
questions. Yes. So let me stop sharing. That didn't work. I was trying external speakers.
We could hear the voice, but it was a bit low, so maybe if you could increase the voice.
Okay. So let me try this again, because I don't know. That's bizarre because let's see here.
Doctor, on sharing part, share your computer audio too.
Okay.
Yeah.
So let me know if you can hear this.
Yes.
You can hear that?
Yes.
Yes.
Okay, okay. So let me try doing this again. So let me increase the volume.
Okay.
Sorry about this. Everyone?
It's okay. It's okay.
Okay. So let me increase the volume here. Make sure the volume is high enough. All right, so this should work now, I hope.
Welcome to the second part of this presentation, which has been
Yes.
pre-recorded. During this presentation, I'll be available to answer questions using the chat feature.
Now it's perfect.
You're all aware that SARS-CoV-2 is the pathogen that
So may I ask, so there is some noise in the background.
Yeah, people should mute themselves, please.
Okay. Go ahead and mute. So I'll go ahead and stop sharing and share again. But please, everyone, whoever is on, please mute yourself, because the volume on my end is quite low on the pre-recorded presentation. Okay, so let's try this again. And once again, I apologize for the delay and the confusion here. So I'll go ahead and start the presentation.
Welcome to the second part of this presentation, which has been pre-recorded. During this presentation, I'll be available to answer questions using the chat feature. We are all aware that SARS-CoV-2 is the pathogen that is responsible for COVID-19. It is a zoonotic virus, that is, a virus that has successfully crossed over from animal species and into humans. Within the human population, it is spread through the air as far as several meters from one person to another. The virus enters the body through the airways and initially infects lung tissue. You are also aware that there are these emerging variants of SARS-CoV-2 that have been shown to be more contagious or more infectious, but are not any more harmful than the original strain. However, as I'll be presenting later in my talk, there is at least one emerging variant of interest, namely the Lambda variant, that is not only more infectious, but also appears to be more virulent or more harmful compared to the existing strains of COVID-2. Now, COVID-19 is quite a mysterious infection because it remains unclear why most of the people who get infected remain asymptomatic or develop only mild symptoms, while a few end up developing severe COVID-19 and even succumb to the disease. Therefore, the underlying reason for this wide-ranging variation in disease pathogenesis is yet to be resolved. However, there have been risk factors that have been suggested for the development of severe COVID-19. And these include old age, So over 80% of COVID-19 deaths occur in people over the age of 65, while more than 95% of COVID-19 deaths occur in people older than 45. Secondly, people with pre-existing chronic health disorders that include cardiovascular disease, obesity, diabetes, and hypertension. And the third proposed risk factor is poverty and a poor access to proper healthcare. Now, in people who seem to be healthy and don't have any apparent pre-existing conditions, but end up developing severe COVID-19 and perhaps even succumbing to the disease, one wonders whether there is a genetic predisposition to developing severe COVID-19. And several recent studies have shown that indeed there is, and have identified regions of our human DNA, therefore genes, whose polymorphisms increase the risk of developing severe disease. So these are based on genome-wide association studies that have identified genes or gene clusters whose polymorphisms increase the risk of severe COVID-19. Although these studies were well conducted and their findings are substantive, they were carried out in human populations that were limited to specific global regions, mainly Western Europe and the US. Therefore, it remains to be seen whether these are the same genetic risk factors that may also be applicable to human populations in the developing world, particularly Africa. So, there is a justifiable need to be able to conduct similar genome-wide association studies with patients of African descent. Another important point I would like to make in this presentation is that it's now becoming clear that COVID-19 is not just a respiratory infection, but is also a multi-organ systemic disease. To the right of the slide is a diagram of the human body with the solid lines pointing to organs or organ systems that are directly affected by the infection. Therefore, where the virus infects the tissues of the organs and is able to replicate. The dotted lines point to organs or organ systems that are indirectly affected by the infection. Therefore, where the virus may not necessarily infect cells, but is able to spread. Or a consequence of a hyperactive immune response to the infection, to the viral infection, is harmful to these organs or organ systems. To the left of the slide, I'm showing a schematic of the manner by which SARS-CoV-2 has been shown to enter and infect cells. So it's an enveloped virus that expresses the protein spike on its surface, which it uses to bind a receptor on the surface of cells known as ACE2. And upon binding, proteolytic cleavage of spike by another protein or protease enzyme called temperase 2 is required for the virus to be able to enter and infect the cells. So, ACE2 is a receptor that is required for the successful entry of SARS-CoV-2 into cells. And once again, just to emphasize, SARS-CoV-2 initially infects lung tissue, more specifically lung epithelial cells, leading to substantial pulmonary disease, including pneumonia and acute respiratory distress. That the virus has not only been detected in lung tissue, but also in other organs, including the liver, kidney, heart, brain, and blood samples in people who have succumbed to the disease. That ACE2 is the receptor used for viral entry, and that it's expressed not just in lung tissue, but also in other tissues and organs, that upon initially infecting the lungs, SARS-CoV-2 will enter the bloodstream and directly infect other organs that express ACE2. So the takeaway message from this slide is that SARS-CoV-2 does not only infect cells of the lung, but that it can also spread and infect cells of other organs that express ACE2. And therefore, the direct infection of multiple organs via ACE2 and the resulting hyperactive immune response to the infection constitutes the basis for severe COVID-19, for the systemic and multi-symptomatic manifestation of the disease. Then there's the issue of these long-term or long-haul symptoms of the disease that has been seen in about 1/3 of symptomatic COVID-19 patients. Then there's the issue of these long-term or long-haul symptoms of the disease that has been seen in about 1/3 of symptomatic COVID-19 patients. So this is long after acute COVID-19, and also long after these patients are no longer testing positive for the virus based on a nasopharyngeal test or testing samples obtained from the respiratory tract. Shown here to the right are some of the symptoms that these patients with post-acute COVID-19 syndrome are reported to experience. This begs the question that is yet to be addressed of why some patients, in addition to experiencing acute COVID-19, why they end up experiencing these long-term effects. What also needs to be addressed are the clinical management approaches that can be used to appropriately deal with some of these subacute to chronic effects of COVID-19. Now, getting to these existing SARS-CoV-2 variants, regarded as either variants of concern or variants of interest, first of all, how do they emerge or crop up? Well, SARS-CoV-2, like any other RNA virus, is prone to acquiring genetic mutations as it replicates and spreads. And mutations that confer a replicative advantage, therefore those that increase infectivity or make the pathogen more virulent, will allow the variant strain to be selected for, thereby becoming one of the more prevalent strains. As of June of this year, 5 major variants have been identified globally, which include the now dominant Delta variant of concern and the emerging Lambda variant of interest. This Lambda variant is currently raising much concern because it's not just more infectious, but is also considered to be more harmful than these other circulating forms of the virus. To the right of the slide, I'm showing scheme diagrams of the genetic structures of 3 of the non-circulating variants of COVID-2. You will notice that the gene encoding spike protein seems to have the majority of these mutations. Therefore, the gene encoding spike is a hotspot for genetic recombination. And so, therefore, mutations in the receptor binding domain of spike that enhance its binding affinity to ACE2 in order to facilitate entry and infection of cells will lead to COVID-2 variants with higher infectivity. Now, in discussing more on these variants, and how they emerge. As early as May of last year, there was already a transition from the original Chinese Wuhan strain to a mutant that became the globally dominant strain at that time. This mutation is on spike, and it allows for a higher binding affinity to ACE2, and therefore for higher infectivity, and consequently a higher transmissibility. It's been shown that patients infected with this mutant strain possess a higher viral load due to the higher infectivity. And once again, it's considered to be more infectious than the original strain, but not more harmful. Another variant, Delta, now makes up essentially all of the sequenced cases in the US and has rapidly outcompeted all the other circulating forms of the virus to become the globally dominant form. Then there's this emerging variant of interest, Lambda, which was first reported in Peru, South America, that has been shown to be more infectious than the circulating forms. In addition, it also exhibits immune escape. So therefore, in viral neutralization assays, it's been shown that antibodies generated upon a natural infection or by vaccination are less effective in neutralizing the Lambda variant. What's also striking about the Lambda variant is that even though it is still considered to be a variant of interest, it's the dominant strain in Peru, making up over 80% of sequenced cases over there. And coincidentally, Peru has the highest number of deaths due to COVID-19 of any other countries, of any other country, in terms of deaths per 1 million people. By comparison, the second highest number is in Hungary, which is half of that is in Peru. So these findings suggest that the Lambda variant is not only more infectious, but that it is also able to escape protective immunity elicited by vaccination to a greater extent, while also appearing to be more harmful. Then there are these commonly asked questions regarding the already approved vaccines. The first question being whether these vaccines are really safe and efficacious, and two, whether these vaccines can offer immunity against the currently circulating variants of concern. Shown here to the right of the slide are some of the already approved vaccine types which have shown good to excellent phase 3 clinical trial outcomes. The subunit protein vaccine from Novavax has not yet been approved for emergency use yet, but in a recent phase 3 clinical trial, this vaccine was shown to be highly effective in inducing protective immunity, even against the variants of concern. The mRNA vaccines show greater efficacy or appear to be more superior compared to the adenoviral-based DNA vaccines or even the Sinovac inactivated vaccine. However, despite its high efficacy, there is emerging evidence that robust protective immunity conferred by mRNA vaccination can last as long as 6 months to a year, but then immune protection decreases with time. Furthermore, waning mRNA vaccine-induced immunity seems to be less protective against variants of concern. I should emphasize here that it still remains protective, but is less protective compared to the original strain. And therefore, a recommendation has been made for a third shot booster, which after consideration by these 3 US government bodies, a decision was made just recently to offer a booster shot that will be administered 8 months after receiving the second shot. Also noteworthy in discussing mRNA vaccines is the adverse side effect with mRNA vaccination, observed with mRNA vaccination, of a low but significant risk of developing mild inflammation of the heart tissues, particularly in young people below the age of 30. Once again, these are very rare occurrences, and fortunately enough, they can be easily treated with anti-inflammatory drugs. Just to touch a little bit more on these variants of concern, I believe Dr. Daisy Umutoni will be discussing these variants in greater detail in her presentation. The data shown on this slide are from a recent study that is yet to be published. It's in preprint format. This study showed that variant forms of SARS-CoV-2 exhibit greater resistance by several fold towards neutralization by antibody-containing sera isolated from convalescent or recovering patients, or from mRNA vaccinated individuals. Therefore, this means that these variants can potentially escape the immunity that is conferred by mRNA vaccines. The same study also compared the effectiveness of vaccination with the DNA-based vaccines in protecting against these variants. And it was shown that antibody-containing sera isolated from DNA-vaccinated individuals are significantly less effective at neutralizing the major variants of concern as compared to sera obtained from mRNA vaccinated individuals. Well, on my end, I have 2 little children at home, one of whom will be resuming her schooling very soon. Clinical trials to determine whether the already approved vaccines are safe and efficacious for use in children are still ongoing. So, is there a reason to be concerned that our children still remain unvaccinated? And the answer is no, that at the moment, children seem to have a much reduced susceptibility to developing severe COVID-19 and the associated pneumonia. And this, for instance, is evidenced by the statistic that as of mid-July, while 14.2% of all confirmed cases in the US were children, only about 1.4% of all hospitalized cases reported were children. Therefore, identifying the basis for the much reduced susceptibility to COVID-19 in children will be crucial to understanding disease pathogenesis, while also providing important clues for effective treatment. Outlined here are some of the proposed reasons as to why children are thought to have a much reduced susceptibility to developing severe COVID-19. This is also illustrated in the schematic to the right. Firstly, that because children tend to have a greater frequency of infection with coronaviruses that cause the common cold, they do have a pre-existing reactive immunity that when they encounter an infection with SARS-CoV-2, they are better protected. Secondly, they have a reduced expression of the ACE2 receptor used for viral entry on the surface of alveolar epithelial cells which form the lining of the lung tissue. And consequently, this reduces their chances of infection with SARS-CoV-2. Thirdly, children tend to have an overall stronger immune response to viral infections. And lastly, and this is an extremely important point, so unlike the adults, children tend to have a lower overreactive or hyperactive immune response to a viral infection. And you may recall from our earlier discussion that this hyperactive immune response is a hallmark or an important characteristic of severe COVID-19. Touching more on the vaccines and their ability to offer protective immunity, I'm showing to the left of the slide photos of an event that occurred last month here in the US. So this was the NBA basketball finals, attended by a very large number of people. Over 65,000 attendees were outside the basketball arena, while over 17,000 were inside the arena. Most of these people had already been vaccinated, and therefore there wasn't a mandate to wear masks or even exercise social distancing in order to be able to attend the event. Now, this could have potentially been a super spreader event. However, the fact that we haven't heard of a negative outcome from this massively attended event is a clear indication that the already approved vaccines are protective enough to be able to allow an event of this magnitude. However, there's the caveat that older adults and immunocompromised individuals are reported to be at a higher risk of a breakthrough infection. That is, an infection occurring in a person who has already been fully vaccinated. Having said that, it's also been shown that for most individuals who encounter a breakthrough infection, even in these higher risk categories of people, the resulting illness is much less severe, and there is a reduced need for hospitalization. Other major reasons for breakthrough infection, particularly among seemingly healthy individuals, is the inability to achieve herd immunity in a population, and also the fact that variants of concern tend to exhibit a greater extent of immune escape compared to the earlier circulating forms of the virus. Therefore, overcoming the dire shortage of approved vaccines in the developing world and the elimination of hesitancy or refusal to get vaccinated due to misinformation that is happening in some parts of the developed world will be crucial to achieving global herd immunity. Now, delving into the status on the development of rapid and more affordable testing. So the goal here, particularly in the developing world, is to test as many people within a short time and affordably while maintaining accuracy in viral detection. Now, RT-PCR analysis of nasal or oropharyngeal samples still remains the gold standard for testing because of its accuracy in viral detection. However, as we are well aware, it is expensive and comes with a slow turnaround of 1 to 2 days. Then there are the commercially available antigen-based or serological testing assays, which have a more rapid turnaround time, but are not reliably accurate. Therefore, substantial error comes about in detecting in either detecting false negatives in the case of antigen-based testing, or detecting false positives in the case of serological testing. And this slide briefly highlights a recently published study conducted by a group based in Rwanda. It is a commendable effort on their part, where they've developed a pooled testing strategy to test as many people using the gold standard RT-PCR, but in an affordable manner. It is my understanding that this strategy is now currently being applied to test large groups of people in both Rwanda and South Africa. What about the status on COVID-19 treatment? And so this is to make the point that there isn't a clinically proven strategy for COVID-19 treatment other than supportive care with repurposed drugs, oxygen therapy, and monoclonal antibodies, with a type or line of treatment employed depending on the severity of the disease. And as you may well be aware, repurposed drugs used for COVID-19 treatment include antiviral, anti-malarial, and immunosuppressive drugs. Important to also note that early intervention with monoclonal antibody therapy has been shown to reduce the risk of severe illness and prolonged hospitalization, especially for people in the high-risk categories. And there's emerging good news that these monoclonal antibody therapies have now been licensed for manufacture by India, which hopefully should make them much more affordable. In the next few slides, I would like to briefly discuss with you some of the research I have been engaged in as it pertains to COVID-19. So this research has involved the expression and purification of SARS-CoV-2 structural proteins, including spike, with the ultimate intention of screening convalescent sera, or even sera from vaccinated individuals, to identify and then isolate effective neutralizing antibodies. I should point out that most neutralizing antibodies that are generated either by vaccination or a natural infection are usually targeted towards the S1 region of spike, which is the region of the protein that binds to ACE2, therefore the region that has the receptor binding domain. So once again, the successful expression and isolation of the COVID structural proteins can allow for the screening of convalescent sera in order to A, identify antibodies that cross-react well with each of these proteins, and B, then proceed to isolate cross-reacting antibodies and further assess their potential to effectively neutralize SARS-CoV-2 infection. On this slide, I'm showing results from a procedure called Western blotting in order to demonstrate that these structural proteins, including spike, can be successfully expressed in lung epithelial cells, and that they can also be successfully purified from these cells. Furthermore, by microscopic imaging, we are able to examine how each of these structural proteins are distributed in cells, which I'll be showing to you in the next few slides. So this is an imaging analysis of the spike protein in lung epithelial cells. In green is the spike protein, and in blue is the nucleus of the cell. And you can see that the spike protein is distributed along the plasma membrane, which is marked here in red, the nucleocapsid, note their differential location patterns. That whereas spike is found to be expressed along the membrane or on the cell surface, nucleocapsid is intracellular and within what is referred to as the cytoplasm. By contrast, the membrane protein of SARS-CoV-2, which should be expressed on the cell surface, appears to be intracellular or to be expressed within the cell. And there is reason to be concerned with this result. Therefore, the fact that we see it being expressed inside the cell and not on the cell surface may explain why membrane protein is unable to elicit effective neutralizing antibodies. The way spike protein is effectively able to elicit these antibodies. This is something that we're looking further into. So, as the pandemic evolves, so must the research. For example, as it pertains to the identification of effective neutralizing antibodies, one has to now consider the SARS-CoV-2 emerging variants. So instead of just cloning and expressing the original or even the earlier forms of spike, to also now consider these other variant forms of spike, then exposing these spike variants or the cells that express them to sera from convalescent or from vaccinated individuals in an effort to identify monoclonal antibodies that cross-react with these variant forms. This would be followed by performing viral neutralization assays to identify antibodies with treatment potential against SARS-CoV-2 variants. In conclusion, important takeaways from my presentation are the following. That COVID-19 is a multi-organ systemic disease that initially disrupts lung function, but can also spread to other organs that express ACE2, which is the surface receptor used for viral entry. That direct infection of multiple cell types via ACE2 and the resulting hyperactive inflammatory immune response constitute the basis for severe COVID-19. That there is a need to conduct genome-wide association studies with patients of African descent to identify genes and/or polymorphisms that increase patient risk for severe COVID-19. That the Lambda variant, which is currently an emerging variant of interest, but could soon become a variant of concern, is not only more highly infectious, but also exhibits substantial immune escape and appears to be more harmful than other circulating forms. And identifying the basis for the much reduced susceptibility to developing COVID-19 in children will in turn be crucial to understanding disease pathogenesis and even providing clues for effective treatment. And lastly, in the absence of effective drug treatment strategies for COVID-19, affordable monoclonal antibody therapy should be considered for reducing the risk of severe illness and prolonged hospitalization. I thank you all for your attention and will be glad to answer any questions that you may have.
So thank you all. And I realize that I've gone way over my time. So I'll turn it over to the moderator so that she can give Dr. Daisy a chance to give her presentation. Thank you.
Yeah, thank you so much, Dr. Yuri. Thank you so much for the presentation. Has been a little bit long, but also educative. Yeah, thank you so much. So for any questions from the participants, please feel free to write them down in the chat box. Dr. will be answering them, and then the others will be answered at the end of the session if there's still more time. Yeah. For now, I welcome Dr. Daisy to take us through the next session, and then later Dr. Alice. So let's try to use time, 40 minutes and 30 minutes each, and then we can have time for questions and answers. Thank you so much. You're welcome, Dr. Daisy.
Thank you, Alan. So my name is Dr. Daisy Umutoni. I'm a medical doctor and I'm also a researcher, just like Dr. Uri. So I'm very happy to have this opportunity to talk about COVID-19, SARS-CoV-2 mutations and COVID-19 vaccines. And thank you all for your attendance. We're really happy that you replied to the call and you're here and we'll be able to learn together. So without further ado, because we are running behind time, I'll just dive into the presentation. If you have any questions, please don't hesitate to write them in the chat and we'll be answering them after the presentation. So just a moment. Yeah, so these are the objectives of today's presentation. Mine is, I'll be presenting it live, no recording. So these are the objectives. I'll explain. It's really a refresher because I know most of you know already about the basics of the immune system, how it works. And then I'll talk about how vaccines work and the types of COVID-19 vaccines that we have, especially the ones that are available here in Rwanda, and the intention for vaccinating, and what about the variants, what has changed, and what should we do. So can you guys see the image? I don't seem to see it very well.
The screen, the images?
Yeah.
Yes,
You can see it?
Yeah.
Oh, okay, just a moment. I'm trying to minimize the members list, but it's covering the image. Just a moment, sorry.
All right.
Oh, I don't know what's happening. I can't find my cursor. Is there a way you could stop me from sharing, Alan, on your side so that I do it again?
Okay.
Is it working? Oh.
I've now stopped the screen sharing. Maybe you could start sharing again.
Okay, I'll do it again. Yeah. Oh, you know what? I will have to turn off the video. Please stop the share again because this video is interfering with my slide.
I've also stopped your video, so I think you can share it again.
Yeah, we can see your screen, Doctor.
Hello, Dr. Daisy. Hello, Dr. Daisy.
Hello, can you guys hear me now?
Yes, we can hear you.
Oh, I'm sorry, my screen just froze and I couldn't do anything. So
please, people in the background, can you mute yourselves?
Hello, please mute yourself.
Hello, please mute yourself. You're interrupting the presenter.
Dr. Nakwani mutins.
but stop sharing. Had a akabazo nagize. Stop sharing, ndongera sharing.
Okay.
Can people mute themselves, please?
So please mute yourself.
Hari abantu murimo kuvugiramo ku buryo ntabwo twumvikana. Thank you. I apologize. My computer had a problem. So I will go on with the presentation now.
I'm going to mute all.
Hello, actually, everyone. Hello, Dr. Daisy, you can proceed. Sorry for that.
Okay. So I'm trying to move my slides, but it's taking time to move to the next one.
Can you send to me, then I share on your behalf?
Yeah, okay.
Right. On
Just
email.
a moment. Yeah. Stop the sharing for me.
Okay.
Moderator, may I suggest that we maybe allow the next presenter to go on as I fixed my issues for now? Because I'm trying to upload the presentation in order to send it, but it's quite slow and I don't want to delay any longer.
Yeah, sure. Thanks, Dr. Daisy, and sorry to the participants for the inconveniences. Yeah, we are really sorry. So I'd like to welcome Dr. Alice to take on and present to us the session. Yeah. Thank you so much. Welcome, Dr. Aline. Sorry.
Thank you, Aden. Can you hear me?
Yes, I can hear you.
Okay, so thank you. I'm Aden Owase from the University of Rwanda, College of Medicine and Health Sciences, and I have a great pleasure to present this topic about recognizing and coping with the burnout among the healthcare professionals in this COVID-19 context. So during this presentation,
Can you share your full screen, please?
I don't know what is happening. Okay.
Down
Yes.
there.
Okay.
Yeah.
So during this presentation, I will take you through the definition of this burnout syndrome, its symptoms, some background information about this burnout syndrome, and some management strategies. And then at the end, we'll have a takeaway message after this presentation. So before starting, I just want to share with you my story that is recent toward this burnout syndrome. And this was in September 2020. One of my friends who was recently appointed to a new position has started to blame his direct supervisor for assigning him too much responsibilities, and few days later, the blame was shifted to his colleagues that they are lazy, they don't like him, and he became aggressive to everyone at work. So since then, he refused to take any kind of break, either including tea or lunch break, and he started combining different responsibilities, including management responsibilities, technical, and even cleaning responsibilities. So during the same time at home, he did not sleep well at night. He used to wake up his wife to discuss his plans to leave the current position for initiating his own business. So one day in the morning in December, on his work, he started by doing his usual office work, then start cleaning his office, because usually he did not allow anyone to enter his office. And then at the end of the day, toward 5 p.m., instead of going home, he went into the institution's warehouse, and then he started again cleaning. So by that time, it's only by that time that his colleagues realized that something might be wrong with him. So they approached him, but it wasn't successful because he was very aggressive and somehow disoriented. So they decided to call his wife, who came and took him home to pray. So his wife invited different people, and they spent the whole night praying for him, but in vain. So in the same night, his wife called me to inform about the situation, and I said, please hold on, I will come on the next day. And when I arrived at his home, I observed him, and I advised them to take him to a health facility for mental health care, which became successful. And then he resumed his work, and now he's working as usual. So this story takes me to the definition of this burnout syndrome. And this burnout syndrome has been defined by different psychologists, but the recent one has been defined by the social psychologist, Christina. And he defined this burnout syndrome as a syndrome that results from chronic workplace stress that is not well managed. And this syndrome combine three different symptoms, which are emotional exhaustion and depersonalization, and also reduced personal accomplishment. And for emotional exhaustion, people with it feel emotionally drained or overwhelmed, and they present different symptoms like changing in mood, which include irritability or lack of motivation to work or even to socialize with other colleagues. And also people with emotional exhaustion present symptoms like thinking difficulties, like being confused, like difficulty in being concentrated to what they are doing. Also, people with this emotional exhaustion experience or present some sleeping problems, like having difficulties to fall asleep or even stay asleep at night. And also some may develop or have oversleep in the morning. So those are some symptoms that characterize someone with emotional exhaustion. For now, this depersonalization, this people have the feeling of being disconnected or detached from their own bodies, and they feel like things that are happening around them are not real, they are not, it's not a reality. Also, people who are depersonalized, they don't care about the world which is around them. So for this reduced personal accomplishment, people with this one, they are mainly feeling somehow incompetent, or they have a low work performance. So the root cause of this burnout syndrome is mainly the major mismatch between the nature of the job and the nature of the person who does the job. And this means that in general, when individuals first enters into their career, they are very motivated, they are very ambitious. But if the work environment is not supportive of their effort or their concern, the reality of the job and the individual's expectation now start to diverge. And then if the frustration or disappointment may begin or may arise from that mismatch. So if the situation is not addressed, then the stress can accumulate, and later on a person may develop this burnout syndrome. So this image shows the person who developed this burnout syndrome, and it shows how much the symptom of this burnout syndrome build up over time, and they evolve from mild to severe symptom. But what matters for this burnout syndrome, it's to recognize those symptoms earlier, and then start taking some steps toward managing those signs or those symptoms. However, if those symptoms are ignored, they could turn into a bigger problems, as we are now going to see. And that big problem is called this burnout syndrome. So different psychologists have identified the phases of this burnout syndrome, and have used this this burnout syndrome that have been developed by this psychologist Herbert, and he has identified 12 phases of the burnout syndrome. And one is the excessive drive or ambition. So as I have said, from the beginning, people are very ambitious. They want to work hard. So, and for some people, that ambition pushes them to work harder and harder, so that for some, they are not able to switch off their work or their job. So, and also at some point, those people who are very ambitious, they can neglect or sacrifice their self-care, such as sleeping, such as doing physical exercise, and even some don't eat well because they are very ambitious. They really want to perform their work very well. Also, being in such a situation, people may start to displace their conflict, or they may start to blame their boss or even their colleagues. So because they are in this case, they are very threatened, or they are very panicky, and because of course the work environment. And also people being in those conditions, or people being in this process of developing this burnout syndrome, some begin to withdraw from family and friends, and even from social invitations, because for them the work is the only focus. So also those people in this process, they become intolerant with those around them, and they can see them as the incompetent or as lazy persons, and even for them, the social life or the social contact becomes hard to them. And also at a given time, they may cut off this social life, which may become non-existent. Also, they can experience this behavior change toward their family, toward their friends, and even towards their colleagues. Also, at a given time, again, those people may develop this depersonalization. And when it comes for the healthcare providers, they don't care about themselves, and even they don't care about their colleagues, and even about their patient they have to take care of. So, and also at a given time, those people feel like they are empty, feel like they are tired, feel like in simple terms, feel like their batteries are empty, and they start to search different ways to charge their batteries, and it's thereby some people may shift to substance uses, and other may shift to overeating, and also at a given time, that is towards the last phase, people may feel that life doesn't have a meaning to them, and they start to feel somehow they are hopeless, and they don't even want to live. And this is very dangerous, and it leads to the last phase, which is the burnout syndrome. And now at this phase, now the person experiences the total collapse, that is the mental and even the physical collapse, whereby the person may be disoriented, either in time, either in space. And in this, remember, in my history, our person, his colleagues realized that he has a problem when he reached this last phase, which is a total collapse. When he started cleaning the warehouse, when he started talking too much to them, when he started to become aggressive, he has reached this last phase, which is the burnout syndrome. So all those phases also can happen for a healthcare provider. You can't talk about burnout syndrome and leave out the stress And if you remember well, we have said that this burnout is a chronic stress which is not well managed. So the difference between them is that stress, people who is stressed experience emotions more strongly. He has energy, or he's hyperactive, but someone who has this burnout doesn't have energy. And this person having a stress may have some physiological changes, like having a high blood pressure or a high heart rate. Whereas for a burnout, now in addition to these physiological changes, now the person also may experience some psychological changes. Also, people who have this stress may have difficulties to concentrate and forget sometime. But for this, with a burnout, they forget more frequently and more easily than those people who are stressed. And also, in the case of stress, the interest in performing his or her job decreases, but for someone who is burned out, has no interest for his job at all. So now this COVID-19 has increased the prevalence of this burnout among the healthcare professionals, and few evidence shows that in Australia, 30% of health professionals developed this burnout. In Brazil, it was 21%. In Spain, it was 41%, and it's unfortunate we didn't conduct any study in Rwanda to see the prevalence of this burnout during this pandemic. But there is a study that has been conducted before this pandemic, and this burnout among nurses in Sehashika, but this burnout, the prevalence of this burnout was high. And now we can assume, or we can think of now the prevalence of this burnout after this or during this pandemic. So why this prevalence of burnout has been increased during this COVID-19? It has increased because of the nature of this virus, as we have seen in the previous presentation. Also because of its higher rate of infection and mortality, because of the lack of the effective treatment, and because some health professionals have to be away from their families, because of the heavy workload, because of the extensive responsibilities, and because of not having enough personal protective equipment, and also because of the fear of contracting these diseases and even contaminating their families. So though this has been identified out of our country, I think we are not out of the same context. So generally, the risk factors of this burnout can be classified into 3 different categories that are a work environment, and this is the core risk factors for developing this burnout. And also some other demographic variables and personality traits also can expose individuals or even the healthcare providers to developing this burnout syndrome. And some examples of work environment that can expose people to develop this burnout syndrome are those work overload. You know, in this pandemic period, the number of critically ill patients has been increased, and people had the huge task to do those mass screening tests. This increased work overload can expose people to develop this burnout syndrome, and also those demographic variables such as younger age, earlier career, or higher level of education. All those can expose people or healthcare professionals to develop this burnout syndrome. Also, some personal or personality traits like people who want to achieve more, people who are more conscientious, people who are more perfectionism, those who are very ambitious, those who want to achieve more, their effort or their ambition can expose them to developing this burnout syndrome. But fortunately, there are some strategies that can help healthcare professionals to prevent or even to manage this burnout syndrome. And also they are classified into 3 different categories. And those are personal lifestyle, professional lifestyle, and also organization level. So for the personal lifestyle, there is one concept which is more emphasized in every book and even in every articles about preventing this job stress and even this burnout. And that concept is to take care of yourself first. I'm talking to the healthcare professionals and even for other people. If you want to prevent this burnout syndrome, you have to take care of yourself. And it is important for the healthcare professionals to recognize that self-care is not equivalent to selfishness. Rather, self-care is essential for energizing, for restoring, for maintaining the physical and emotional stamina to reduce that fatigue and then to be able to manage the stress. So some examples of those self-care activities include this having adequate sleep, include this having proper nutrition, participate into regular physical activities. Those are examples of activities that you can do for taking care of yourself during your regular activities. Also, I want to add on this that managing stress requires a high level of self-awareness. You have to be to communicate with yourself, and this also helps to prevent this burnout syndrome. And you have to be able to recognize the specific factors that causes stress and how you yourself you deal with them. And there is different ways, many ways that you can do. There are many different exercises that you can do to evaluate your level of your work-related stress. So another personal lifestyle that you can help you is just to keep your social relationship, to remain connected with your friend, to remain connected with your family, and to remain connected with your colleague. And if possible, or when needed, request for the support. Also, another point that can help you is just to seek a professional counselor. It may happen that this stress persists and it is not well managed. Remember that when this stress is not well managed, will lead you to a total burnout syndrome. So if you feel those kind of feeling of anxiety, of hopelessness, which persists, please go and see the professional counselor. He may or she may help you. So on the side of professional lifestyle, the core managing or the core preventive measure is to work smarter. And what does this mean? Working smarter mean setting some realistic goals. Set the goal that you will be able to achieve for you to be happy at the end of the day, instead of being guilty. So also working smarter also may mean taking time away from your working environment or from your working station. And this doesn't mean to leave your job. It can even be taking only a few minutes at a time to stretch, to take a walk, to make your personal phone calls, to just sit and relax, because this will help you to recharge and will help you to improve your performance. So also for your professional lifestyle, you can plan for those kind of CPDs because they help you to renew the passion for your profession. And also you may plan for becoming an advocate for either yourself or for either for your colleagues. And becoming an advocate, meaning to become familiar with some policies and examples of some policies that can help you to advocate towards this burnout syndrome prevention can include some policies regarding some breaks, regarding the limit for working hours or overtime hours. So those are a few tips towards this personal lifestyle. And then for another tip that can help you also is about the communication skills. This is not easy for everyone, but for a healthcare professional, you have to learn how to communicate effectively with your colleagues, with the patient, with everyone around you. You have to learn how to communicate effectively with all those people. Now for the organization level, this may mainly regard some people in leadership positions. So they have to create a healthy working environment that encourages people to work, that engage in participatory decision making, and that yes, helps people to cope with this stress-related work. So now, without taking much time, I want you to just have a takeaway message. And this is that one, COVID-19 has increased this burnout syndrome in everyone, but specifically in healthcare providers. Two, burnout is a chronic stress that is not well managed. And this means that once you feel some signs or some signs of distress, please don't ignore them. Three, this burnout syndrome results from the major mismatch between the nature of the job and the nature of the person who does the job. This means that during your usual work, if something goes wrong, please try to seek some ways of managing it. Try to talk to your supervisor, try to talk to your colleagues so that everything can run smoothly. So fourth, this burnout syndrome occur gradually, and any sign has to be given a particular attention. 5, the risk factors of developing this burnout syndrome include environmental or working areas factors, include demographics, and also some personality traits. And 6, to cope with this burnout syndrome, you have to think about personal lifestyle, you have to think about professional lifestyle, and also some organization factors. Now, having attended to this presentation, and this specifically on this topic, I want you to always remember those following statements. During your usual work, remember those following 2 statements. And they have been stated by Dr. Joseph, and I quote him. He said that as physicians, we owe our patients 2 things, only 2 things, our time and our skills. We do not owe our patient our lives. And this means during your usual activities, give your time to the patient, give your skills to the patient, but never give them your lives. Remember to take care of yourselves. So how? Also, he said that doctors must take some time off from their daily work to get some rest, to travel, to participate in their family affairs, and to be an active member of their community. And this means, please, on your schedule, also plan for other activities that are different from your daily work or from your usual job. So I thank you. Those are the references, and your questions are welcome.
Thank you so much, Dr. Aline. This was really an interesting topic. We are really grateful, but since we are running out of time, I would like to welcome Dr. Daisy to also take us through the session. There are some questions in the chat box. I think we'll answer them at the end of the session. Thank you so much. You're welcome, Dr. Daisy.
Alan,
Yes, Dr. Daisy.
I'm told that you were sent my presentation.
Yes. Hi, Agnes.
So you should be sharing it instead.
Hello, let me share it in a minute.
Okay. Hi, Alan. If you're having trouble, Uri says he can share it. Are you okay? Alan?
Hello, yeah, let me try and see if it fails in.
Oh, because he says he is ready to share it, so.
Okay, can you see my screen now?
Yeah.
Okay. I think it's trying to load, it's taking time. Sure.
Okay, should we ask Uri to share it?
Can you see it now?
Okay, now I can see it.
I'm trying to move to the next page, but it doesn't.
Yeah, that's the
I
same
think something
problem I
is-
had. Yeah.
I think Dr. Yu should try sharing.
Okay, okay. Please, Dr. Uri, could you share now? Okay, thank you, Uri. So first, I really apologize for this technical issues that were very unforeseen, but we'll try to make sure this doesn't take too long because we already passed the time limit. So I already presented myself, so I'll just go ahead to the next slide and the next one. Yeah, so I wanted to just give us a refresher of how the immune system works, especially against viruses. I suppose that a good number of you already have an idea. So first of all, when our body is attacked by a viral infection, the body responds first using the innate immune response. It's the first responder. And this happens using natural killer cells, the cell in purple. Sorry, I can't use the cursor, but I hope you can follow. And natural killer cells respond in an antigen-independent way. So they don't need to be activated by an antigen. And they can directly destroy infected cells, the ones below, and at the same time, they can release cytokines called interferon gamma. And these also, they participate in causing formation of proteins that also stop the virus from replication. But at the same time, these cytokines also participate in now stimulating cells or activating cells of the adaptive immune response, which are B cells and T cells. And so this adaptive immune response takes normally in an unvaccinated person or someone who is not exposed previously to the infection, it will take a couple of days or more to respond. So that's why it's adaptive. It comes after the first response, the innate immune response. So the B cells will be activated and produce antibodies, which are shaped like a Y shape. And these will release, the antibodies will destroy the virus, but also B cells are of two types. So one of them, after activation of the naive B cells, one of them is a plasma cell will be formed, and that type of
Sorry, Dr. Daisy, you can go on.
Okay, so the B cell, naive B cell, when activated, it forms a plasma cell, which is the one that will release antibodies. And then it also forms another type of cell called the memory cell, and that's the one that remains behind. And it's already aware of like the type of the antigen that are on the surface of the virus or the invader. And the next time you will skip the innate response, and the adaptive response will be, there'll be like a quicker response because the the memory cell will just quickly produce antibodies without having to go through the whole process. And therefore, you have a quicker fight of the infection and less severe disease. Another cell that is involved is T cells. So the T cells are also activated. They're activated through the MHC1 and MHC2 molecules that are usually found on the surface of infected cells. So they activate naive T cells. It's not shown here, but the naive T cell is like the one that produces other types of T cells. And one of the type is the cytotoxic T cell, which here is called CD8+, and it will destroy the invading, the infected cell. And it will also produce, the naive T cell will also differentiate into a CD4 cell, which is not indicated here, but that is known as the helper T cell. And it's the one that helps to also activate B cells and continue to also activate T cells for further response. So that's just a refresher of the immune response to a viral infection, not just COVID-19. Next. So this is just a schematic that shows because of either exposure to natural infection or vaccination, the body usually has antibodies, again, the Y shapes, to different infectious agents like measles, the flu, chicken pox. But when we have a new pathogen like COVID-19 that is new to our body, we don't have any antibody against it. Next. So what happens, again, this is the immune system review. So what happens now when it comes to vaccines, how do they function in our body? So starting, again, going back to the immune system, when your body encounters a germ, it can take several days to make use of all the fighting tools it has. But after the immune system, after that infection, the immune system will remember what it learned. As I explained before, the memory B cell, and also some T cells will remain behind, and they can remember how the previous infectious agent looks. And this time, they know how to protect your body faster. So the body keeps a few T lymphocytes called memory cells that go into action and quickly, and when the body encounters the germ. And so when the familiar antigens are detected, the B lymphocytes will produce antibodies and attack them. Next slide. So the vaccines will imitate the agent that they are vaccinating against. So if it's SARS-CoV-2, most vaccines that we have are made of mRNA that leads to the formation of the spike protein of the SARS-CoV-2 virus. So that will train your body because it looks like the real infection, but it will not cause illness. But it does cause the immune system to produce T lymphocytes and antibodies against the real infection, because the vaccine came in looking like the real infection, but it won't make you sick. So once the imitation infection goes away, the body is left with the memory T lymphocytes and B lymphocytes that will remember how to fight the disease. Next slide. So Uri already showed us this slide. I just wanted to show, he showed something similar. So it's just a repetition, but again, just to show the structure of the SARS-CoV-2 virus and the ACE2 or S2 receptor, which is actually the one that the virus needs to attack our bodies. And is found in different organs, as Uri explained, not just the lungs, but in other organs as well, the heart, the kidneys, the intestines. And so the spike protein is what usually is the one that attaches to the ACE2 receptor using the S1 subunit, which you can see up there. So I won't go much into the scientific details, but it was just to show you how the spike protein looks and how it attaches to the receptor that, that the virus needs to enter cells. So the next slide. So now I'm going to talk about the vaccines, the COVID-19 vaccines. This image shows the different platforms of COVID-19 vaccines, and I'll just go over them quickly. So on the left side, you can see the top part, inactivated viruses. These are, I will talk about it later, but just quickly, the inactivated virus is part of the whole virus type of vaccines. So it just means the DNA or the genetic material of the virus has been inactivated, in that it cannot replicate and cause disease, but it still looks like the real virus. So it can cause your body to create an immune reaction that will protect you. And just below it is the next type of whole virus vaccine, which is a live attenuated virus. And this one it's live, its DNA is not completely destroyed, but it still has, it has been weakened in a way that it cannot cause you disease, but it will cause a stronger immune reaction. Your body will have a stronger immune reaction because it's still a live virus. And just below it is the viral protein subunit. Here they just take a small piece of protein of a virus, any piece that they want to use. So this type of vaccine will not cause you many side effects because it just brings in a small part of the virus, but it will cause a weaker immune response compared to like the live attenuated type of virus. And then the mRNA vaccine is like the ones we have now, the Pfizer, Moderna, and others. So this one, as you know, is just a genetic material, and they will choose a part of the virus and then make a genetic material that will go into your body and tell your cells to produce that part, like the spike protein. So maybe I'll just explain one more, which is like the one at the top, the viral vector. Because we have vaccines like the AstraZeneca that uses this one. Actually, it's just, they carry mRNA, but the mRNA is put into this viral vector as a carrier just to help it to attach and enter into your cells. So the virus vector they're using now is called adenovirus, and they just weaken it in a way that it's usually empty. So it doesn't have, it's like a shell. It doesn't have the ability to cause you that adenovirus infection, but it has other properties on that shell that will help it to go and attach to your cells and easily allow the other mRNA they put inside to enter your cells. So that's why it's called a viral vector vaccine. So I'll go to the next slide. So this is just, again, and what I just previously explained. So I'll skip this slide. Can we go to the next one? Yeah, so here I just wanted to outline just a few details, updates on the COVID-19 vaccines that are now approved. So the emergency use listing is a listing that the WHO puts either drugs or vaccines on. The reason it's called emergency use is because usually they take so much time, years even, or sometime a decade to actually study a particular drug or vaccine before they approve it. So given the short time that we had these vaccines approved, they can only be allowed to work through a channel called emergency use, meaning that in normal times, they would need further studying, but because they were already showing good efficacy and we were in a pandemic and needed a quick response, they put them on emergency use listing. So these are the ones that are currently approved by WHO, and those are the countries where they are produced. And the other column just shows the time when they were approved. But it doesn't mean that if a vaccine is not approved by the WHO, it cannot work in like some countries. For example, Sinopharm has only recently been approved last month, but it's been working in China, some Asian countries, even some African countries. So WHO just gives guidance, but countries can choose what to do. So the next slide. So I just wanted to give more details about some of the vaccines that we have here. So this first one, ignore the scientific name, it's actually the Pfizer vaccine. It's an mRNA vaccine produced by cooperation between BioNTech, a German company, and Pfizer in the US. It's a 2-dose regimen, as you all know. Some of you may have received it already. And in the study that was done, a 2-dose regimen confirmed, like the clinical trials that were done before its approval, after 2 doses, they found that it conferred 95% protection against COVID-19 in persons 16 years of age and older. And the safety over a medium of 2 months was similar to that of other viral vaccines. So some of the side effects of Pfizer that were found during those clinical trials ranged from mild to moderate pain at the injection site, fatigue, and headache. So the incidence of serious adverse events was low and was similar in the vaccinated and placebo group, meaning the group that didn't receive the vaccine. So although the vaccine can be stored up to 5 days at standard refrigeration temperatures, once it's ready for use, very cold temperatures are required for shipping and longer storage. So this is a caveat. Next slide, please. This is the AstraZeneca vaccine that we have also been seeing a lot here in Rwanda. And it consists of a replication deficient chimpanzee adenoviral vector. So this is something I talked about before, that they use like a shell of another virus. Here they use a chimpanzee adenoviral vector, means it's usually found in chimpanzees, but they make sure that it cannot do anything to your body. It will just be used to carry the SARS-CoV-2 mRNA. So majority of the clinical trial participants were aged 18 to 55 years in the clinical trials before it was approved. And overall efficacy across both groups, meaning the placebo and the vaccine group, was 70%, 70.4%. So the vaccine can actually be stored and distributed at 2 to 8 degrees, making it suitable for global distribution. Next. So I didn't talk about Sinopharm, but it's actually has been availed to Rwanda, and we hope we'll know more about it as well. But as I mentioned, it's been approved by WHO and has been working in different countries before, and it's now in our country. So the limitations of the current COVID-19 vaccines So they are, according to the current knowledge, they are only known to prevent severe disease and hospitalization and death, but they don't have data on preventing asymptomatic disease. They have not yet really understood if they can prevent asymptomatic disease and transmissibility. And actually, we have seen that people who have been vaccinated can still get infected. So the duration of vaccine protection has not yet been confirmed, but Pfizer recently released data. I think Uri talked about this as well, that the protection wanes after 6 months, and therefore they would like to propose. They've actually been making a booster, and maybe some countries, I think Israel has already started vaccinating people or giving them the 3rd dose, which is the booster. So subgroup trials have not yet been concluded. Again, it was mentioned before that children have not been included in these clinical trials or studies for vaccines. Pregnant women, race and ethnicity. So most of these, as Uri mentioned, most studies are done in the Western part of the world. And so there is that limitation that there may be some nuances and things that pertain to other races that make us different in the way we respond to vaccines. Therefore, in future, they need to expand their studies to African countries and other races. So dose regimen and need and timing of boosters. So those are also things that have not yet been understood. The next slide, please. So now I'm going to talk about mutations and variants, and then how it connects with the vaccines. So mutations, as many of you may know, is that these are changes in the sequence of amino acids of the virus due to changes in the sequence of its DNA. So if there's a change in the genetic material, because we know that the genetic material tells the body which proteins, amino acids and proteins to make, then the amino acids will also be different, substituted or added or removed or changed in a different way, and that's a mutation. So this happens as viruses replicate. So because during replication, normally there is actually a check, a mechanism that makes sure that the genetic code is not changed when the virus is replicating, but sometimes there's like a fault in that check, and it leads to it, like the mutations go unnoticed, and therefore, produce variants, as I'm going to talk about later. So because this happens a lot during replication, if we manage to reduce virus transmission from person to person, this reduces possibility of variant formation. So not only transmission from person to person, but also when immunocompromised people get infected, they have prolonged illness, prolonged hospitalization. And during this time, they give more time for the virus to keep growing and replicating in their body, because there is no strong immunity to stop it. And the more replication that occurs in a given time, the more chances of having a mutation. So mutations are common among viruses, but only a minority of them confer characteristics that actually allow the virus to thrive, to not die. Usually most mutations will kill the virus, but some of them actually give it a favorable characteristic. And as maybe some of you may know about evolution, survival of the fittest. So the virus that acquires those survival characteristics will prevail. And just like the Delta variant has been the most frequently tested virus of late in different countries, it means it acquired some favorable characteristics and actually leads to the diminishing of other variants. So it takes over in a way. So the effects these mutations can cause, for example, they can allow the virus to escape the immunity, either acquired naturally through disease or acquired by vaccination. They can lead to reduction in response to treatment. They can impede diagnosis. For example, the virus can cause its antigen to change because of the mutation, so our rapid test will not be able to detect it. So they can cause ease in transmission. They can increase disease severity. Next slide. So a variant is just a virus whose DNA has acquired one or more mutations, thus varying from the original. And viruses with the same set of mutations in their DNA are grouped together to make a lineage or a clade. Next slide. So the WHO and other bodies like the CDC in the US, they continue to monitor the SARS-CoV-2 mutations and variants based on sequencing, meaning they'll take a sample from an infected person and they will try to read the DNA of the virus in a lab, and also epidemiological studies. So that's how they have been able to classify variants into variants of interest and variants of concern. And also the CDC has an additional classification called variants of high consequence. Next slide. I will explain further about these definitions. So here is a table that shows the variants of interest that are currently under this classification. And you can go ahead and look at the time they were classified, the countries, but I'll just go on to what a variant of interest is. So this variants of interest are the ones with genetic changes that are predicted to affect transmission, diagnosis, therapeutics, or immune escape. So if they have genetic changes that are already known or predicted to affect these things like transmission, diagnostics, and also there's evidence that they cause an increase in proportion of cases, either in the community or clusters in multiple countries, or if there's evidence of epidemiological changes other than these ones mentioned here that can be a threat to global public health, these variants will be classified as variants of interest. So mainly they will have genetic changes that will cause those effects like transmission, diagnostics, therapeutics, immune escape. And in addition, they will affect the number of cases, either in communities, they'll drive them higher, and also in multiple countries, and they could cause other epidemiological changes. Next slide, please. And there's also a variant of concern, and these are the ones we were talking about, Delta and Alpha. These are like the serious ones, if I may say. So basically, they meet the criteria of variants of interest, but in addition, they have one or more of other characteristics like increase in transmissibility or detrimental change in COVID-19 epidemiology, or they increase the virulence or clinical presentation of the disease. And also they cause a decrease in effectiveness of public health measures. For example, we're using masks, washing hands, social distancing. So some of these, despite these measures being in place, they will not be as effective as before. And I think if you guys can remember, before the government announced that the Delta variant was in Rwanda, we had like a crazy spike of infections and most measures were not working. So that's one of the signs of a variant of concern. Next slide. So I mentioned that the CDC has another classification, which is variants of high consequence. And this, fortunately, we don't have them yet in the world. So these will impact medical countermeasures. So they cause a demonstrated failure of diagnostics. They show evidence, there's evidence to suggest a significant reduction in vaccine effectiveness, a disproportionately higher number of vaccine breakthrough cases, meaning cases who are vaccinated but still get COVID-19, or very low vaccine-induced protection against severe disease, and also significantly reduced susceptibility to approved therapeutics like the monoclonal antibodies and the other drugs, and also more severe clinical disease and increased hospitalization. So yeah, they basically kind of ignore all the medical countermeasures available, but we don't have any variants under this classification yet. Next slide, please. Excuse me. So here I just wanted to mention some of the variants that were reported in Africa. The Beta variant is under variants of concern, and it has been shown to infect more younger demographic than older people and causes more severe illness. Scientists have found that it contains several mutations that allow it to attack human cells with more ease. And the variant has so far spread to Zambia and Botswana. Next slide. The Delta variant, as I mentioned, it was already confirmed to be in Rwanda. It's a variant of concern and causes increased transmissibility and is said to spread as fast as the Alpha variant. And also in July 2021, which is last month, another variant was found which has same mutations as Delta, but with extra mutations, and it was called the Delta Plus, and it has also started spreading internationally. Next. So the Eta one is a designated variant of interest, so it's not as severe as the last two, and it was first detected in the UK and Nigeria, but it has been seen more in Nigeria than the UK, and it's still under study by experts. So they want to see if it really causes more risks that warrant any concern for it to be moved to the variant of concern. Next slide. So sorry?
Yes, I think
we're running behind time. I'm almost wrapping up, so just a few more minutes. So this is just to mention about efficacy of vaccines. I know Uri talked a lot about them, but I just wanted to add this because there's concern that why are we seeing people who are vaccinated still get infected? So there was a study that was done in New York that shows that concluded that currently available vaccines have higher effectiveness for preventing laboratory confirmed SARS-CoV-2 infection and COVID-19 hospitalization. However, vaccine effectiveness against infection appears to have declined in recent months, coinciding with a period of easing societal public health restrictions and increasing the Delta variant circulation. So basically in this study, they found that there was reduced waning immunity in people who were vaccinated against infection, just carrying the infection, but there was actually stable defense against severe COVID-19 and hospitalization. And they found that maybe one of the reasons that the immunity reduced against like getting infected is because there was also an easing of public health restrictions during this time. And also it was the time the Delta variant had started circulating. So they concluded that they support a multi-pronged approach or multi-layered approach to reduce new COVID-19 hospitalization and cases centered on vaccination and including other approaches such as masking and physical distancing. And also, there's been similar studies in other countries, so it's not just this study in New York that also had similar results. Next slide. So a quick mention of the goal of vaccination is to achieve herd immunity. And this is basically like population immunity. I know most of you are aware, but I'll just go over it quickly. This is basically like vaccinating a big part of the community so that even a few people who may remain unvaccinated will still be protected because there will be very little transmission because of the vaccination. So this is the aim that countries have and the world is to achieve herd immunity of their populations. And for COVID-19 vaccine, they have found that at least 60% of a population has to be vaccinated in order to achieve herd immunity. So we are hoping Rwanda can achieve that next year, as we have been told by the Ministry of Health. Next slide. Next one. So the bottom line is that vaccines, like any medication, can cause side effects, and the most common side effects are mild, at least for the vaccines that we have now. However, many vaccine-preventable disease symptoms can be serious or even deadly. So I'm sure a lot of you have know or have someone or know someone who knows someone who has been severely affected by COVID-19. So even with advances in healthcare, the disease that vaccines prevent can still be very serious, and vaccination is the best way to prevent them. And when fully vaccinated, you have a significantly diminished risk of severe COVID-19 and death from COVID-19 compared to unvaccinated individuals with similar risk factors. The next slide. So I just want to acknowledge some individuals or groups at the end of this presentation. The National Research Foundation that has funded these projects and allowed us to do these workshops and other activities to help in the fight against COVID-19. And also Health-Edu that is actually organizing this workshop and many more to come. And also I want to thank all of you for being here, for giving us your time, and we really apologize for going over the time that we had mentioned. So thank you for being here. Thank you for your participation. And yeah, we hope to get any questions. If we don't answer them today, we're going to make a list, a file with all the questions, and we'll give you back the answers as soon as possible. Thank you very much.
Thank you so much, Dr. Daisy, for the presentation. I don't know if there are any questions. You can do, I think, get about 25 questions. If there are any, please write them down in the chat box or raise your hand. Then you can give the questions. Yeah. I want to thank everyone that has participated, the participants and the doctor. Thank you so much. We have a question from that has been answered, but we can see with it. We have a question from Mr. Example. Why the managers are not trained about burnout syndrome prevention? I think this was to Dr. Alice. The chat, but we know that managers should be trained about how to recognize and manage burnout syndrome so they can put together organizing and managing these changes. Yeah, thank you so much. I think I have someone that raised their hand.
Alan, your sound is, you're very far. It's like you're very far. I don't know if I'm the only one. Can
Okay.
barely hear.
Can you hear me now?
Yeah.
Yeah, so yes, thank you. I would like to welcome Mrs. Francisca. Her hand raised up. You can ask your question. Thank you. Please unmute. I'm trying to unmute you, but you're mute. Mira Kaliza Francis, please unmute and ask the question. I'm trying to unmute you. Right. Is there any other question from the presenters? I can see so much appreciation from the chat box. Thank you to the presenters for the good presentations, and it was really insightful. Yeah. We are still waiting for Mrs. Mira Kaliza Francisca to unmute and ask. All right. I can see a request in the chat box for presentation. That certificates you'll get them from the Health-Edu platform. So please, Agnes will send the link in the chat box below. Then you can get the link for you to get the presentation. Thank you so much. Unless there's any other question, I'd like to give Daisy to give us the closing remarks as we close the session. Thank you so much.
Thank you, Ellen, for moderating. And thank you, everyone, starting with the presenters, Dr. Uri and Aline, for being here and sharing all the knowledge with us and with everyone else. I believe we've learned a lot. I personally learned a lot. I thought Aline's presentation was really great, and I can practically use a lot of some of the advice. And Dr. Uri, also, thank you for the great explanation about the science behind all this COVID-19. I really gained a lot of knowledge and will keep following it up. Thank you again for all the people who attended. I saw a lot of a wide range of healthcare providers, doctors, physiotherapists, nurses, pharmacists, and this is really good because you guys are the ones who are fast responders and also are in touch with a lot of people who ask you questions because they believe that you know. So we hope this added something to your knowledge, and we can answer questions when we will send you the answers for any more questions, and you can always reach out and ask us. Maybe we can share our emails in the chat box in the meantime, but yeah, I'm so happy that we could learn together, and thank you for your time. Again, apologies for all the mishaps that happened. And finally, thank you so much, Health-Edu, for organizing this workshop. And last but not least, our funders and supporters, the National Research Foundation of South Africa. And we hope to have more workshops like this in future. Someone please, maybe you can mute all of us. Yeah. Okay. So thank you again. And we will have more workshops. I'm very sure of it, and we'll let you guys know, and you can join us with other presenters and other topics, other interesting topics. So thank you so much. Have a nice weekend. Bye.
Thank you. Bye, everyone. Have a nice weekend.
Thank you.